has been improved a lot. But in 2008, there was another government, and actually about 4 to 5 hours a day, there was no power in the office. And there was also poor work environment. There was actually poor ventilation, there was poor light, etc. And our staffs are also very unskilled and they were frustrated. And because they didn't have any email address even. So they did not know actually what is their future and for which purposes they were engaged in the health system. So this was the situation in 2008. We used paper forms, and on average, actually for gathering data from the lowest level hospitals in the country, on average it took about 2 months. And in 2009, a new government, actually which is continuing now, the government of our Honorable Health Minister here, headed by Honorable Prime Minister Sheikh Hasina, they took over in January 2009. And this government came with a vision called Digital Bangladesh Vision 2021. And yesterday, in one presentation at least, or maybe in several presentations, you understood what is Digital Bangladesh. So, Health Ministry also actually tried to establish the HEC part of Digital Bangladesh. And the immediate areas of activities we identified, these are infrastructure development, capacity building in terms of maybe giving training to the health staffs, and also maybe acquiring developers who can actually develop software for us, and monitoring and supervision. Also advocacy through visible results, because we understood that if we can actually show results to the policymakers, policymakers will be more willing to actually invest money for improving the e-health so that the health situation is improved and the citizens get better care. And we also actually tried to do a building information culture in each of the health organizations across the country. But we did not forget that we have huge population in the country, we have got resource constraints, we have got competing health priorities, and we have got shortage of skilled ICT staffs across the health sector. Then the solutions we have chosen, these are very simple, these are low cost, these are innovative, these are locally appropriate, and these are scalable. So this is the new look of the same building. In 2009 we did it. This is the digital training facility in the same building, and we call it's only one piece in the country, because the whatever digital actually facilities which are available in this digital facility, these are not available in any of the training room or the auditorium or conference room in the country. This is our national data center, and we have also a disaster recovery center 300 kilometers away from Dhaka in Khulna, and this is located in a place which is not actually disaster prone or earthquake prone. So this is the status of the connectivity as of now. All the government hospitals, all the teaching institutions, and all the administrative offices, they have got their computer connected in network. And actually we are building this, currently they are actually providing data using the district health information system. But by this time in all the public hospitals we have installed the open MRS. And we are actually working for connecting all the hospitals so that one patient record can be portable from one hospital to another hospital. All the daycare clinics, that means the outpatient clinics, which include 13,000 community clinics located in the tiny geographic area of Bangladesh, they have a laptop and internet connections. All the community health workers, they are called health assistant, assistant health inspector, or health inspector under the Director General of Health Services. Their total number is 24,000. They have got a tablet computer connected with modem. Regarding choice of the software, initially we tried to actually limit ourselves to only one software. The reason is that actually we considered the skill and the education level of our grassroots level health worker, but we failed to do that. At last actually we have chosen 3 software, not more than that. One is District Health Information System for collecting grassroots data for the public health programs. One is Open MRS for actually making the hospital automation and hospital medical record system. And the third one is Human Resource Management Information System. We wanted to build also a local information culture. So we provided laptops to every sub-district, every district, and every division. Every month, they use the database and automatically generate a report to hold the monthly meeting and to actually assess the local situation, compare the situation between time, and compare the situation with neighboring areas. We also publish a local health bulletin for every organization. and this is automatic health bulletin. Every organization fill up an online form and a health bulletin is automatically produced. So they have to publish locally and defend the data they use inside the local health bulletin. And every year there are a convention of annual MIS conference where actually in presence of us they have to come and they have to defend their data. And in this year, actually this week and the next week, this will be taken place in 7 divisions of Bangladesh, where all the actually health managers from the grassroots level, as well as the supporting staff working for MIS, they will gather and they will present their cases and they will defend the data in presence of dignitaries and also journalists. And if you actually visit our website, if you actually search in Google and you write DGHS space Bangladesh and you give enter, you will have our website. I request you to visit the data menu under the website, and these are the public view. We call it Bangladesh Health Observatory. And please click in every link and you will understand actually how we are using e-health and mHealth for improving the accountability, for improving the transparency, for improving the data collection and data use for evidence making. So in this slide, I'd like to give a snapshot of our e-health and mHealth programs. So these are the list and I like to read out for you. So DGHS, my department, our agency, they have at least 12 actually major e-health or mHealth programs. So one is consistently improving the health information system, engaging all stakeholders, private, public, or NGOs. We have a telemedicine program, and 3 kinds of telemedicine we provide. One is by mobile phone, this is we call mobile phone health service. Another is video conferencing using the Skype platform. And the third one is advanced telemedicine, where we use dedicated bandwidth and big screen with many peripherals. In this session, you will have the opportunity to see how we are delivering the telemedicine services. Then yesterday you have observed how we track the mother and the child so that you can achieve the MDG4 and MDG5 under the COIA model. COIA means Commission on Information Accountability on Women's and Children's Health, and this is an initiative launched by the Ban Ki-moon, the Secretary General of United Nations. The third one is health workforce accountability. Fourth one, the health workforce accountability. This includes human resource management information system and tracking them, remote time attendance, and also the complaint suggestion box given by the clients of the health facilities. We have got a stock of 98 million citizens records, and with this data, we are actually trying to build a lifetime portable shared health record so that when a child will be born, his or her health record, electronic health record will be created, and throughout the life, these electronic health record will be updated, and wherever this baby or this man will go, this actually health record can be possible to retrieve, and the doctors will actually see this record, update the record, and give the treatment based on the record. We have got hospital automation program and we are using OpenMRS. The policy is for the public hospital, we'll actually provide the hardware as well as this software, but the private hospital will distribute this copy free of cost. And we have acquired this software free of cost. This is an open source software. I thank to GIZ. The GIZ helped us for customization of this software for using in Bangladesh, and this is absolutely free. So what we'll do, we'll actually use it in the public facilities by our own, but we'll distribute it to the NGO hospitals and the private hospitals free of cost, and they will acquire their own hardware and they will do the hospital automation system. So this will create a system that entire Bangladesh hospitals or health facilities will be connected to the same network, and data can be portable from one hospital to another, and at the national level we can actually produce the statistics about the hospitals. Then we have actually created also a framework for data standardization and interoperability. After the launch, there will be another session where actually I shall show you how our framework is working and actually the initial work we have done by this time. Then we have got one CRVS. Yesterday there was a presentation from World Bank headquarters and they have mentioned about CRVS. Bangladesh is possibly going to be the first country in the world actually which will be a case for the whole world to demonstrate how a country can implement universal civil registration and vital statistics systems. Then we use the mobile phone for health awareness campaign through text, and also we actually distribute mass voice call. 2 or 3 months back, our Honorable Prime Minister actually mass distributed the voice call, encouraging the common people of Bangladesh to take the services of community clinic. And there was about 30 to 40% increase just after the voice call given by the Honorable Prime Minister. We have got actually online admission test for the medical and the dental students. We have got web portal and the social media, and in this session we'll also demonstrate you how our web portal or social media are working. And we are going to soon launch under the initiative of the Prime Minister's Office e-filing system. That means across the health system, we'll actually do all the file management electronically. Probably we are not going to use paper file anymore after that time. So DG Family Planning is another agency under the Ministry of Health and Family Welfare. And they have got supply chain management system and a number of other systems. And Director MIS of Family Planning is here. In this session, he is going to give another presentation on the DGHS e-health or mHealth initiatives. Under the Ministry of Health and Family Welfare, we have got separate initiatives. These are annual development program monitoring. We have got every year there is an annual development program, and the financial management is done by this system. And the ministry, sitting in the ministry, and they hold a meeting, and also they evaluate the progress of the annual development program implementation with the software. This software is also used by all the different agencies of the ministry to understand actually how their progress is taking place. Then the ministry has got a procurement plan. So all the major procurements undertaken by the ministry are done by this procurement plan. And we can track the procurement through this system. Finally, the ministry also uses an online leave management. So the health staff, particularly the doctors who want any leave, so they have to apply online, and the ministry processes these applications online. And I think in this conference, you have also seen the public-private initiatives, and some of the important public-private initiatives which are being supported by the Ministry of Health and Family Welfare are up on John. I think in the morning, this has been presented. On M-Care, yesterday from the Johns Hopkins University and Jivita, you have got a presentation on M-Care. There is another program, MTICA. I do not know whether there is, I think there is a presentation on MTICA. This is also a joint collaboration, and we thank the Johns Hopkins University. They are actually working with us as our active partner. And finally, actually WHO is going to help us to build e-register. Actually, this is the transformation of the paper registers used by the community health workers. And actually, we are trying to automate these systems. So these are the recognitions. Yesterday, you have seen that in how the global community have recognized Bangladesh. So in 2010, WHO published a gold book, which we call the landmark publication, and that helped us to get recognition from the United Nations. And 2011, our Honorable Prime Minister received the United Nations Award for Digital Health for Digital Development. And we have got in 2013, there is another publication by WHO. And if you visit this WHO publication, you will understand what progress Bangladesh has made. And in this year, 2014, the German Federal Ministry of Economics and Cooperation recognized Bangladesh across all the GIZ supported program by the German government throughout the world. Our health information system has been recognized as the best practice in the world for 2014.
Us to make this ideal work even better. Thank you.
So, thank you very much, and this is the end of my presentation. Next, I shall invite Dr. Sultan Samuel Basar. He is the Officer on Special Duty Management Information System of DG Health, and actually he is going to present telemedicine programs by Ministry of Health and Family Welfare in Bangladesh.
Thank you, sir. Honorable Chief Guest, distinguished audience, ladies and gentlemen, good afternoon. I'm Dr. Bashar. I'm from MIS under Ministry of Health and Family Welfare. Today I'll try to give a brief overview of the telemedicine services provided by us. So here is the agenda. Firstly, I will tell about the mobile phone health services. Then we shall talk about the advanced telemedicine service. Then other telemedicine services for grassroots levels, and something about the infrastructure and standards. Mobile phone health service. This is actually a voice call based service. People usually call in multiple numbers which are provided in websites and also in bulletin boards in different hospitals. As Professor Azad said, this is not technologically very advanced, or this is only a regular voice call. And some of the mobile phone operators do have the same services, the 789 services. But this service has some advantages, like first of all, this is costly. The calls are just regular voice call. And this is very locally appropriate. I mean, there are multiple, in 789 systems, there is only one number and doctors are centralized. But in this system, there are multiple numbers. People can talk to their own hospital or the hospital in their vicinity, and so local context is there. And it is also 24/7. One DT doctor maintains this telephone, and he or she has to register the call details. And of course, this is free of charge, and this is very convenient for the women and the children because they do not have to travel to hospital each time, and also it is less hassle. And we are trying to roll out this to 18,000 community clinics gradually. Now, for telemedicine services, we have advanced telemedicine service with high quality equipment, and then telemedicine service for in-home information centers through Skype calls. And then we have telemedicine services through field health workers and community clinics, that is using the laptops and the tablet PC. First of all, the advanced telemedicine service, we use dedicated high bandwidth telemedicine solutions. They are placed in 43 hospitals spanning all the divisions of Bangladesh, and this number is increasing gradually. And these are used for referral consultation, and of course it is free of charge. So these are some devices we use in this telemedicine service. You can see the multi-point camera for tertiary hospitals, and we also use telestethoscope, pulse oximeter, telemicroscope, teleskin camera, blood pressure machine, glucometer, and tele-ultrasound, and some other. So I wanted to show some video, but for time shortage, I've captured some of the screenshots from the video. These are from the real cases. So this is a picture of teleskin camera, and below you can see the skin, what can be seen by the remote doctor. This is a snapshot of tele-ultrasound. This is what the doctor see at the remote end. And this is a pulse oximeter. The heart rate and oxygen saturation is being seen in the remote end. So those are a few examples. And here are the number of patients. You see, it is increasing day by day, year by year. In 2003, the number of patients we have serviced is over 5,000. And in number is exponentially increasing. So those were the advanced telemedicine, but we have also services for the grassroots levels. The Ministry of Local Government operates over 4,000 Indian information centers, and from those centers, the telemedicine service is provided through Skype call. So one doctor in our office sits to see the patients. So here is an image of a typical Indian information center, and this patient is being consulted by a doctor who is sitting at the MIS. In community clinics, we have already distributed around 13,000 laptops. And here also with Skype, we can provide telemedicine services. The doctors in this case sit in the sub-district level hospital. And last but not the least, the use of Android mobile phones, which are given to more than 20,000 health workers. So they are also using their Android devices to provide telemedicine services. Now about the infrastructures and standards we want to maintain. Regarding the devices, we usually use the Cisco single or multi-point camera. And regarding bandwidth, at least 1 Mbps dedicated bandwidth for the advanced telemedicine services. And we use LCD or LED monitors. And we are using ATA standard equipment. It is American Telemedicine Association equipments. And the provider are, of course, they are qualified medical practitioners, and the presenter, the community health workers, they are certified by the medical practitioner. And in future, we are trying to integrate these services with OpenMRS, and we will adopt the all data, video, and image exchange standards like the DICOM standards. So that's all. Thank you very much.
Thank you, Dr. Sultan Samiul Basir. And I like to invite Engineer Shukhendu Shekhar Rai. The health works, he is the System Analyst, Management Information System, Director General of Health Services.
Guest of honor, respected chair, distinguished guest, ladies and gentlemen. Assalamualaikum. Welcome to my presentation. The title of my presentation is Health Workforce and Accountability. Large number of workforce work under Director General of Health Services. Director of Health is responsible to give the service to the citizen. So accountability is more important to improve the quality of service to the citizen. MIS, on behalf of Minister of Health and Family Welfare, is working to establish digital Bangladesh as well as digital health since last tenure of the present government. MIS is doing many things in this regard. So we developed standard organization registry photo from this system. I can show you. No need to PC always on. Actually,
any inconvenience or discomfort because of our shortcomings. In Bangladesh is a country of success now.
Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon. Ladies and gentlemen, our special guest from Philippines and Pakistan. It is my great opportunity and honor to present here in this today regional conference on health, informations and e-health. তার অত্যন্ত খুশি হয়েছে হেলথ কমিউনিটি ক্লিনিকে এই ব্যবস্থাপনা দেখে। তারা হেলথের ক্ষেত্রে আমরা যে এগিয়ে গেছি, আধুনিক প্রযুক্তি নির্ভর যে স্বাস্থ্যসেবার ক্ষেত্রে আমরা এগিয়ে গেছি, তারা অত্যন্ত প্রশংসা করেছে। এবং আমি মনে করি এই ক্ষেত্রে আমাদের অগ্রগতি যেটা আছে, এখানে যারা বসে আছেন আপনারা, একটা মোবাইল টেলিফোন দিয়ে ভিডিও কনফারেন্সিং এর মাধ্যমে গ্রামে গঞ্জে আপনারা মানুষকে স্বাস্থ্যসেবা দেওয়ার জন্য বিশেষজ্ঞদের পরামর্শ নিচ্ছেন ঢাকা থেকে। আমি কদিন আগে গিয়েছিলাম, একটি মেলায় গিয়েছিলাম, কম্পিউটার মেলায় গিয়েছিলাম। সেখানে দেখেছি কিভাবে গ্রামের মানুষকে স্বাস্থ্যসেবা দেবার ক্ষেত্রে বিশেষজ্ঞ ডাক্তারদের পরামর্শ নেওয়া হচ্ছে ভিডিও কনফারেন্সের মাধ্যমে, মোবাইল টেলিফোনের মাধ্যমে নেওয়া হচ্ছে। আমি সেখানে দেখেছি আপনারা সফটওয়্যার তৈরি করেছেন যে ডাক্তার সাহেবরা সেখানে স্বাস্থ্য কমপ্লেক্সে আছে কি নাই, কাজ করছে কি করছে না।
Good afternoon. I am Mirza Rakibul Hassan, working on MIS as an IT consultant. So, as my previous speaker says about our e-health services, our data collection software and how we collect the data and how we use it. I am here to accumulate these all things. I am here to manage the data, how it is published or how it is organized for public view or to the viewers.
Minutes to deliver my lecture, but I have prepared 27 slides. Due to short span of time, perhaps I would not be able to express all the things elaborately. So I will discuss very shortly. At the beginning of my speech, I'd like to say that I am very happy to be here with you in this prestigious conference.
Thank you so much.
Thank you, Professor Nazrul. So actually today I'll present it's as like other presentation is a public-private partnership project called Move IT. The reason is that we know that from Bangladesh data that the loss of pregnancies and deliveries in Bangladesh and birth and immunization. So one of the slogan for this conference was actually universal health coverage, which is very important. But if we actually went through the presentation, yesterday's and today's presentation, mostly what we focused on from the global policy to the information at the ground level, which mostly focuses on actually the experience of the different kind of mobile health and e-health experiments that happened in Bangladesh last couple of years. For universal health coverage, if we look at the data, one of the problem is that to reach universal coverage, we need the denominator. And for denominator, we need unique ID, because if somebody looks at the Bangladesh data, all kind of data we have mostly cross-sectional, although currently because of the mHealth technology, we are actually getting the information on continuum of care. So the Move IT is a project monitoring of vital events through information and technology. And it was conceptualized by my former dean, Timothy Evans, who is at World Bank now. And it was supported by WHO Health Matrix Networks. And we do have partners, Empower, BRAC HNP, Health Nutrition Population Program, and BRAC ICT. So the objective, as I said, that one of the major objective was assignment of a unique ID, which National Population Register at Access to Information in Prime Minister's Office, they were working on that, which is very important because I'm reiterating again that to reach universal health coverage, unique ID is very important. In particularly Bangladesh, while we are in the actual epidemiologic transition from maternal child health to non-communicable disease, while for follow-up data or continuity of care data, unique ID is essential. The other object is actually the registration and also collect the information on continuity of care. And it was actually going through different phases, starting from the content design to software design and then pilot testing and implementing at the field. What we did actually that we implemented in the northern district Rangpur, and it is a longitudinal data that we have collected. And we focused on the married women and also the children, under 5 children for immunization data. So the data collection stages that we collected different data on continuity of care, but also the vital registration, which includes birth, death, pregnancy, and immunization. So the reason we started to experiment, that one of the unique characteristics of this project that we experimented with both government community worker and private worker, which is BRAC Shastro Shevika and the government health assistant. And they collected the data, the pregnancy care data, the child care data, the registered pregnant women and the birth. The unique ID that we have used, because we know that there is no such unique ID currently exists in Bangladesh. Mostly if we look at the DIHS2, information is more geographical data. But that's one of the challenge actually for Bangladesh with all mHealth and eHealth, because I know that there will be session on interoperability, but if we don't have the one individual ID, that information cannot be exchanged between the health facilities and the health workers. So what we came up with, that we actually followed the strategy of National Population Register, where that automatically this ID will be created, but at the same time we also collected the national ID data and also the birth registration. The second part of this unique ID is to link mothers with the baby so that both mother and baby can be tracked for the information. So this is the real-time data we have collected, and it was actually collected through using the mobile phone. I think you have already explained lots of information about the mobile phone data. So far we have just had the piloted for 2 months. It's still now it's in preliminary phase. And if you look at the data, that one of the important factors we found that it's the continuity of, there's a gap in continuity of care. So lots of women come for pregnancy care, the fast care, but not necessarily all of them actually complete their antenatal care at the end of their pregnancy. There is also the low birth weight. But most interesting thing I want to focus on that, we have discussed a lot about the quality of the data, quality of service, which mostly depends on the timely services. And then if you look at the EPI fast dose, which is supposed to be actually given within 28 days of birth, we found that almost 80% of the children were not actually started, they did not start their fast dose on time, and which is very, very important, because in terms of the quantitative of data, I think we have achieved the coverage, but not the quality of the service. So what are the experience of from the field? One of this definitely is the motivation, the reduction of workload if they use the smartphone. This is the feeling of empowerment, which we have witnessed witnessed from the video, that the health worker felt more empowered because they're using the smartphone. But there are lots of problems. Sorry, I have that infrastructural barrier, or whatever, the electricity and the internet. But what is the future implication? Implication is that we don't, now, many other sub-Saharan African countries, the Bangladesh is suffering from pilotosis. I think one of the agenda will be for this conference to bring all of them project together and offer a comprehensive mHealth, eHealth project for the community, and linked it to the health facility, the community data with the health facility data, increasing the community awareness for the timely services, particularly for immunization and pregnancy care, and definitely example of the public-private partnership. So my last slide is Henry Ford, who said that if everyone is moving forward together, then success takes care of itself. And it seems to that through this conference, it has been proved that all of us are moving together at the same time, but we just need to harmonize and act together and bring everything on the same platform. So thank you very much.
Thank you, Professor Malavika Sarkar.
Have to be made, so based on which this application helps the ASHA remind her of the visit, like the first visit is due, second visit is due. There are 2 reminders that are sent to ASHA, and if she still doesn't visit, then the reminder goes to her supervisor to follow up. And there is an expected beneficiary form which includes the information like, what is the expected number of pregnant women in that particular ASHA's area.
With health workers here in Bangladesh. So first, a little bit about BKMI. We're a USAID-funded project. We began in 2011. We've gone through a bit of an evolution. Currently, our project is funded for the next 3 years, implemented by JHU CCP and together locally here with BCCP. The main purpose of the project is to support the Ministry of Health, basic things like opening it, turning it on, opening a window, closing a window, things like that, as well as the 2 resources that were on the netbook, the toolkit and the e-learning. Of course, some of them had, but we wanted to make it as simple as possible so it was easy to use, easy to navigate. So from here, someone needs to click on one of those categories, personal communication, and one on very interested and happy and excited to learn about this technology.
By mothers, but that can be changed again based on the socioeconomic status of the target population. It could be reduced or decreased. And in this program, mother had a chance of 20% at each fill in the daily registers, which was already a hassle, and then entering the data, same data in fact on the phone was added trouble. So we offered a flat incentive of around $60. 2 months into the program, we realized this is not working. Obviously by the end of the project timeline, we wouldn't have achieved the desired target. So we said, okay, it's time to change the strategy.
Out of time, and we are expecting some VVIP to arrive in this place. So I'm giving some time limit, so we can entertain 3 to 4 questions. Please raise your hand and introduce yourself.
Dr. Deepak, and the issue of multiple signals for birth notification is one that I find especially exciting. When there's an absence of information, it's always valuable to get multiple sources of information and then extract the truth after the fact. Could you maybe talk a little bit about how you reconciled multiple reports of a single birth, and how did you verify whether in fact they were a unique event or distinct events? And my second question is to Dr. Subhash, who I also have to congratulate for really bringing the concept of innovation and thinking outside the box to this conference. I think it's really a testament to the innovations going on in Pakistan with demand-side financing as part of this whole health revolution. But my question to you is about scalability and institutionalization. Have you done calculations to look at what the cost might be to take this lottery-based system to scale? So,
the management is not possible at home, then he needs to be referred to the health facility, nearest health facility for proper management. So that was the main elements of this project. So